Michael, we have the patient. Sandy's helped us understand how to think about decision making. Ty's helped us understand how do we think about removing the primary tumor. We know we will have information about their next generation sequencing as well as their histology. And we're left in 2017 with a large list of options. So many of them are targeted, most targeting the abnormalities in kidney cancer that we've talked about, and that is VHL abnormalities. How do you start to navigate through that decision making, and what drives you to choose the agents available?
Right. So in 2017, I think we're in a frustrating situation, at least outside of protocols, because we have two treatments that dominate the front line landscape, pazopanib and sunitinib, which have been around for a while. We know that they are very good in terms of producing prolonging progression-free survival, can produce responses in 40 to 50% of patients, but they also have side effects, and for the most part, they're non-curative, and somewhere between 9 and 12 months on median, patients are going to progress and then need other therapies. And then we have all these second-line therapies, which are probably better than the first-line therapies, but haven't been tested fully in the front line. And so we're often faced with making a decision of having to give patients treatments that are not the ones we want to give them in order to make them eligible to have their insurance pay for the treatments that we would like to give them. And so that's why I think in the first line, I always look to see if there's a research protocol that's available. In my view, and this comes from my days of doing high-dose IL-2 way back 20 plus years ago, my view in approaching a patient with metastatic kidney cancer is still to try to cure them. And I view the other therapies as primarily palliative, and so I would look for protocols, if possible, that involve immunotherapy as my first-line treatment, as the first approach. If a patient is not eligible for an immunotherapy or protocol, or doesn't have access to high-dose IL-2 and doesn't have symptomatic metastatic disease, I delay as long as possible starting VEGF inhibitors. If I'm forced to start a standard VEGF therapy, I'm leaning more towards pazopanib than sunitinib. The COMPARE study that we talked about before indicated that the outcome of both median PFS and median overall survival between sunitinib and pazopanib was similar, and pazopanib is a little better tolerated, and also from the Pisces study, probably preferred by patients and physicians. And unless the patient has liver function test abnormalities, I would probably choose pazopanib first. If they have some LFT abnormalities or some reasons why I would worry about their liver, I might choose sunitinib first, and try to move towards instead of the traditional 4 and 2, 4 weeks on, 2 week off therapy, a 2 week on, 1 week off therapy, which is in general better tolerated than the standard approved therapy and is now an acceptable alternative.
So Sandy, let's extend that a little bit. So again, at ASCO this year, we had 2 abstracts, one by Dr. Bjornson from Toronto, another by Eric Jonash from MD Anderson. The Jonash abstract was a prospective 2-in-1 schedule trial. The Bjornson trial is a trial that we've been waiting for, which is a more tailored approach. Using what Michael said about if you're going to use sunitinib, do you think these observations change the way you approach the dosing and the schedule?
I think it's amazing. We have had these drugs for 10 years, and it's hard to imagine that we are still talking about dosing. But I think it's true. We really don't have a clear idea about what's the optimum dose. Like Michael, I think we have all moved to dosing sunitinib as 2 weeks on, 1 week off. It's definitely a better tolerated regimen. But I think this tailored dose of going, we are very comfortable about dosing down. So I think everybody's familiar with starting at 50, maybe coming down to 37.5, and then even going down further. I think the innovative approach is really going up. So in that trial, they went up to 67.5 in patients, provided they were able to tolerate it well and had a pretty good response in terms of the outcome. So I do think that tailoring it makes a lot of sense. Dose seems to be really important. I think it's true going back to the adjuvant PROTECT trial. I mean, the best outcome were in patients who had 800 milligrams of pazopanib. So it really seems like optimum dosing is important for a good outcome.